Good morning, everyone, and welcome. On behalf of the Mississippi Center for Justice's Health Justice Division, thank you for joining us for today's webinar in recognition of Global Zero HIV Stigma Day. We are honored that you've chosen to spend your time with us for this important conversation. Today is about more than discussing HIV. It's about discussing the systems, policies, and attitudes that continue to impact people with HIV in Mississippi and across our nation. Despite extraordinary scientific advancements, HIV stigma remains one of the greatest barriers to equitable healthcare. Unfortunately, that stigma is often reinforced through outdated laws and policies. Mississippi's HIV criminalization law, in particular, makes it a felony to knowingly expose someone to HIV, regardless of whether transmission actually occurs. This harsh criminal penalty discourages testing, delays treatment, and ultimately undermines the very public health goals it was intended to support. And that is why today's conversation matters. Before we begin, I'd like to share a few housekeeping items to ensure a smooth webinar experience. First, today's webinar is being recorded. Second, we encourage you to submit questions using the Q&A feature. We will reserve time towards the end of today's program to answer as many questions as possible. And lastly, closed captioning is available for those who would like to use it. Our hope is that each of you leaves today with a better understanding that HIV is not a crime and that stigma has no place in our laws. Thank you again for joining us and for your commitment to building a healthier Mississippi. At this time, Alicia Reed Owens, Deputy Director of Health Justice, will introduce our panelists and our moderator.
Thank you, Lisa. Good morning. It is my pleasure to introduce our esteemed panelists. First, Dominique Grant. Dominique is an HIV advocate, speaker, and HIV case manager with Jackson Hines Comprehensive Health Center in Jackson, Mississippi. Diagnosed with HIV in 2015, Dominique has transformed her personal journey into a national platform for education, advocacy, and hope. Dominique serves as a 2026 HIV and Faith Ambassador with Wake Forest University School of Divinity, and HIV is not a crime ambassador with the Mississippi Center for Justice, and is a member of the Mississippi HIV Planning Body. She also serves as chair of the Southern Health Alliance Community Advisory Board. Through her platforms, Walking in My Reality and Her Uncanceled, Dominique's message is rooted in faith, resilience, and authenticity. I live higher in victory because of HIV. Dr. Thomas Dobbs. Dr. Dobbs is the Dean of the John D. Bauer School of Population Health at the University of Mississippi Medical Center. In addition to his role as Dean, Dr. Dobbs is an active clinician and researcher with a focus on the intersection of disease and the social determinants of health. He is active locally and nationally, supporting approaches that improve health and well-being for all populations. Prior to his appointment at the University of Mississippi Medical Center, he held numerous leadership roles within the Mississippi State Department of Health, including state epidemiologist and state health officer. During his tenure as state health officer, he directed the state's response to the COVID pandemic. Attorney Jada Hicks. Attorney Hicks earned her Juris Doctor from the North Carolina Central University School of Law. While there, she was certified in civil rights and constitutional law. She received her Bachelor of Arts in Criminology from North Carolina State University. Prior to joining the Center for Health and Law Policy, she served as an inaugural Judicial Fellow for the Administrative Office of the Courts. While there, she provided independent and confidential legal research and writing support to more than 370 judges in North Carolina's Superior and District Courts. Previously, Attorney Hicks worked as an assistant district attorney for the Pitt County District Attorney's Office. Dr. June Gibson. Dr. Gibson is the president and chief executive officer of My Brother's Keeper, a nationally recognized public health organization headquartered in Ridgeland, Mississippi. With more than 2 decades of experience, Dr. Gibson has built MBK into a premier institution advancing sexual health, primary care access, and community wellness across Mississippi and the South. She earned a bachelor's degree from the University of Southern Mississippi, a master's in education administration from William Carey College, and both a specialist in education leadership and a PhD in urban higher education from Jackson State University. Our moderator, who will be guiding this discussion, is none other than Attorney Linda Dixon. Attorney Dixon serves as the Health Justice Director at the Mississippi Center for Justice, a position she has held since November 2008. In this role, she leads 2 statewide initiatives to advance health equity, expand access to health care, and address systemic barriers affecting underserved communities. Attorney Dixon, take it away.
Thank you so much, Alicia. And good morning, everyone. Welcome again, and thank you for joining us for this important conversation. It is a privilege to serve as your moderator. I want to begin by, first of all, thanking each of you for being here. Today's conversation is especially timely because although we have witnessed extraordinary scientific advances in HIV prevention and treatment, one thing has not progressed at the same pace: our laws, our policies, and in many cases, our attitudes. So we're going to jump right on in to the first question, the first discussion question, and this I'm posing to the entire panel. What do you see as the biggest misconceptions about HIV that contribute to stigma and discrimination?
I'm happy
Dr.
to
Dodd, go
kick us
ahead,
off.
Jada.
I would say one of the biggest misconceptions is that HIV is still a threat in the same way it was understood in the 1980s, meaning people still think of HIV as a death sentence. I find that I hear that quite often. You know, as we've already heard on this webinar, treatment and antiretroviral medication, people living with HIV can live long and healthy lives. And we also know that U equals U, people can be undetectable and untransmittable sexually if they are on medication as well. And so I think people really don't understand how far science has come, how far the treatment has come, and what that really means for people living with HIV, living and thriving with HIV, really. I think another really big misconception that I see is about individual behavior, that HIV is a result of someone's individual behavior and life choices, instead of really framing it as, in reality, HIV outcomes are really shaped by structural determinants of health. So access to healthcare, housing, insurance, and Medicaid, transportation, culturally competent medical care. So I really think that those structural factors are often ignored and work in a way to reinforce stigma without addressing the root causes. And lastly, I'll say that I think one of the biggest misconceptions is that only certain people get HIV, that it's never going to affect you and your life. And that's simply untrue. And in fact, one of the ways that I see this feed into stigma is most highlighted by one of my trips to Mississippi, Linda, where I attended a panel there, and a woman living with HIV was telling me about how her husband had passed from AIDS-related complications. And that was a result of him being too fearful and ashamed to get on medication and get into treatment. He didn't want people to know that he had HIV. He didn't think he was the type of person that got HIV. And so he just ignored that he had it, and therefore never got connected to care, never got into treatment, and ended up passing away. And so I think people really need to understand that HIV could affect anybody. It could be me, it could be you. It doesn't matter the lifestyle you lead, what color you are. HIV does not discriminate.
Thank you, Jada.
And
Dr. Goss?
that was wonderful. What a great start to the conversation. And I can only sort of reinforce how much I agree with everything you said. And I'm glad you brought up those issues because I think it extends beyond the general community, but to the clinician and provider community. This is where I find myself really stunned. Even to this day, things happen that just really sort of blow my mind. This whole sort of concept of it's a death sentence. And so, as an example, there's a fellow that I'm taking care of now who I had to keep taking him off of hospice because the local doctors kept putting him on hospice. And I'd call and they'd say, why? I'd say, why is he on hospice? And they'd say, well, they say he's going to die. And I'm saying, he's not going to die. Get him off hospice. We'll treat him. He was sick and he's still alive and doing fine. He's doing great now. And so that sort of thing amazes me. And the other thing is too, I think there's a lack of understanding of the resources that we have available to make sure that people have access to care. And I've also seen a lot of, you know, clinician under awareness of the resources as far as like the Ryan White program, access to medications, access to clinics, such that, you know, it's kind of like throw your hands up in the air and say, well, the medicine's too expensive, so I'm not even going to prescribe it. Like, holy moly, just get them to where we can take care of them, you know, and we'll do the rest. But the provider community, the clinician community has a long way to go to making sure that we do everything we can for our patients.
Thank you. Dr. Gibson or Dominique,
Yeah,
you want
I'll just add a tiny piece to that
to?
from the helpers of the country and the funders of the country. There's this idea that HIV is their biggest problem. Like everything has to be poured into this. It's the only thing that we can focus on. In Mississippi, we have all the disparities. And most HIV isn't going to kill them. There's so many other things that's happening within this person's body, but we center on that because that's where the money is centering. That's where our goals and objectives are centering. But you have to be more holistic with that with care because they need everything at this particular point. But to only focus on the HIV component of their life and make that the forefront for them all the time, that's just an injustice to anyone. No one highlights your blood pressure everywhere you go. No one's, so it's not this thing that you have to keep putting at the forefront. It's healthcare. And to treat it like that, that is one of the biggest misconceptions that it has to be treated differently.
Thank you for raising that. Dominique, did you want to weigh in on this question?
Yes, I was going to say that a lot of people just treat it and associated with shame instead of it being recognized as a manageable disease. And I think that's where we miss our mark because as soon as people hear HIV, it's like, blah. And they don't want to recognize that it's very much manageable. And you live a long, healthy life. And if you don't take care of your body holistically, then HIV is the least that you have to worry about.
So Dominique, thank you. In
You're
your
welcome.
role as an ambassador and being in community, what are some things that can be done to help dispel some of the myths and misconceptions about HIV?
First, I think we have to become comfortable in having that conversation. We have to be willing and stop being afraid. A lot of people want to ignore the conversation. A lot of stigma comes from fear. And when you have fear, you have lack of understanding. And when you don't know something, you assume something. So assumption and thinking, you have to kill it. You have to be knowledgeable and know. And when you know the facts, you gutter that thing. And so a lot of times when people just are not accurate and they have miscommunications, it's just one rumor after one rumor and one rumor after another one. But for me, I would say visibility, being able to break stigma, walking in my reality as a person of lived experience is big on my end because my story is education. I am education. I'm a walking billboard. And if you ask me, what does HIV look like? It would be me because it has no face, it has no value. Like it can happen to anyone. So we got to stop categorizing. What does it look like? Does it look like a homeless person? Does it look like your pastor? Does it look like your teacher? The person you drop your child off to school every day. And I think we got to continue talking about prevention, testing, treatment. All of those play a big part of HIV and identifying the person People living with HIV, mothers, doctors, lawyers, caregivers, community members. We just got to stop seeing HIV through the lens of fear and start seeing it through the lens of compassion, education, and humanity.
Thank you so much for sharing your experiences, Dominique. So we know that stigma is deeply rooted in a lot of discriminatory practices and laws. And I'll pose this question to Jada. How do HIV criminalization laws contribute to stigma? What does that really look like?
Yeah, I think HIV criminalization laws really codify the stigma that we see about HIV in society into the law itself. And to me, that sends a really big message about folks living with HIV and how we see them, right? It sends the message that HIV is dangerous, that is something where you should be criminalized for it, right? And so I think it really shapes how people see themselves. If there's someone living with HIV, how you're treated by other people, whether they feel safe seeking healthcare or even talking openly about their status, disclosing their status. I really think HIV criminalization laws work to reinforce and produce stigma in that way. Um, which is crazy because, as we know, and as we've already touched on, all of the advances, including U equals U, PrEP, PEP, we have come so far when we talk about transmission and HIV in and of itself, and the law has just not kept pace. And what that really says to me is that we have decades of fear, misinformation, and stigma, not only written into the law, but written into the fabric of the legislature itself. And so we really have to work to do that education around where we are today and what we understand about HIV, and use the law as a tool to catch it up with what we know scientifically about the roots and risk of transmission surrounding HIV as well. And I think we would be sending a different message if we were able to do that.
Well, thank you, Jada. And that your response sets the tone for our next few questions when we look at and explore stigma in the clinical setting and community care. Let's talk a little bit about that. So I'm going to pose these questions to Dr. Dobbs and Dr. Gibson. What can providers do to check their implicit biases towards patients with HIV?
That is such a great question. And certainly it's very important to make sure that as clinicians, physicians, NPs, whatever your role, that we understand what is our mission. And our mission is to provide holistic care to all of our patients, right? And we all have some biases. And if it's something that somebody needs, we need to step back and say, what does this person need? What are we providing for them? And everyone should do a pretty introspective look, and it's not just even about, sort of like HIV or sexual risk factors, but also substance abuse, mental health. Sometimes these are topics that are taboo. And for clinicians to really sort of like, what is taboo for you, and think about it, and how can you grow? In the PrEP space, this has been a very big challenge because we've encountered some major reticence on a couple of fronts. One of them is going to be to even get a sexual history, right? I mean, that's such a critical part of someone's health. Having a comfortable sort of landscape for assessing a sexual history. It doesn't have to be extensive, but we got to understand what people's risks are. We ask people about smoking. We understand all that. So understand that. Listen to your patients. Understand what they're saying. One of my favorite things about the PrEP guidelines is if someone asks for it, that's an indication, right? People understand their lives better than we do. And I've got a lot of interesting stories about how that has played out in a positive way. And also, too, don't try not to bring whatever philosophical, maybe religious restrictions people have. We're kind of a conservative state, and I have seen that interfere with patients' care in the exam room, over moralizing. So, gosh, there's so much that needs to be done. We have a long way to go.
Thank you for that. Before Dr. Gibson responds, can you please, you are Dr. Gibson, for those who may not be familiar with PrEP and what that means, if we could just share with attendees what that means.
Yeah, just real quick, we have phenomenal medication that can prevent HIV transmission. We have both pills that people can take pretty much every day, or for men sometimes periodically, and we have injections that, if taken properly, will prevent HIV transmission essentially 100% of the time. Absolutely wonderful. What a phenomenal resource we have that is underutilized in the state of Mississippi. And in fact, our PrEP utilization rate is the worst in the country and then some. I think we're still even below Puerto Rico. So we've got a long way to go in preventing HIV transmission. And June, I'll kick it over to you.
Thank you for that. And Dr. Gibson, again, what can providers do to check their implicit biases towards patients with HIV?
Well, of course, education. You have to stay up to date on what you're doing. You can't continue to provide services the way you've always done it. And that's in any act in healthcare. You have to become learned. You have to become intelligent about what you're doing. Because if you don't, your implicit bias can slip into explicit bias. And I think that's a place that we find ourselves most often than not, is that people are actually being very explicit about it. And Dr. Dobbs said it best. The first thing I did was to put him in hospice. Again, you haven't taken opportunity to learn about it. So, okay, you're implicit. You just don't know. But when you get into that more than religion and how you deem someone worthy of healthcare based on what you feel is incorrect, you become very explicit. And so understand how you're treating someone. Educate yourself on your biases and know where they come from. And I don't think that happens enough. There's often this idea, because I am a clinician, I should know best, and that I have the capacity to put my feelings aside. You're human. And as humans, we have a perception of things, and our perception becomes our reality. And so if you don't broaden that perspective to understand the communities that you're serving and to want to do better, then you find yourself being very explicit in how you treat someone. You put your gloves on differently. You stand back farther. You don't want to shake their hand. You do these things because these are things that you have determined to be correct. So educating yourself about yourself and understanding how you play a role in providing healthcare.
Thank you. Dominique or Jade, if you want to weigh in on that, please feel free to do so. No? Okay. Dr. Gibson, how has the community clinic care delivery model helped to bridge gaps for people living with HIV? Share with us what that looks like.
Well, in our realm, as community-based organizations, before we entered into the clinical space, we were frontline workers. We were there. We went to the funerals. We held your hand. We made sure that you were linked. We sat there with you. And as time has gone on, because we learned, because we had to become learned about what was happening. We had to change. Just like in HIV, things change. We had to change. And so we went into the clinical space. And within that clinical space, we held the same values true, being community and ensuring that we can reach people where they are, that we can travel and make sure that people can find us, that we're not this obsolete place that you have to look for. And when you come into the clinic, you don't know what's getting ready to happen next. So community-based care is really, they there's this impression that if the community-based care goes away, that healthcare can survive it, and it can't. Community care does things that the healthcare system can't. I mean, we're able to provide transportation, housing, mental health, food. All these things are more of a one-stop way up for the community. And I think that that makes a difference, and it helps to close the gap. You don't feel as if you're being judged because you don't have housing. Someone asks you if you need housing. You're not judged because you can't get a ride. The first thing we want to know is, do you need a ride? So
Mhm.
with the community-based mindset, we're jumping to what we know is happening to you first, so we can build you up so that you may not need our ride one day. So the community system, yeah, we want to change it forever. We want to ensure that this HIV care and prevention that's impacting your life does not have to be the center of your life. and that we're able to meet you where you are and get you to the next step.
That's that holistic approach that you spoke about. Jada, you mentioned, thank you for that, Dr. Gibson. You mentioned in your earlier comments about U equals U and and how it's transformed HIV science. But HIV law has not kept the pace with scientific advancements. Now, how do we rationalize that?
I'm
I
like,
know.
do we rationalize that? The wheels of justice grind slowly. I think it's really difficult when a law is written based on fear and misinformation to then at some point change that law, right? Um, we've talked about how we've made a ton of advancements in treatment and the care of people living with HIV, really, really significant public health advances in our HIV history. And unfortunately, this isn't something where the law is going to automatically catch up to those scientific advancements. We're really seeing a delay and a lag here. Um, and we know that these laws were really enacted during a time of fear. There weren't a lot of treatment options. It was very limited. There was very little understanding about how HIV was even transmitted. And I think what we see are a lot of assumptions that have been embedded into the laws. Um, and changing them really requires targeted, pointed legislative action, education, and advocacy. And as many people here know, requires changing hearts and minds. I think there is just a lot of misconceptions about people living with HIV in general, and it's really easy to associate people living with HIV as a boogeyman, right? And that's used to justify keeping these laws on the books and not updating them. And so it's unfortunate. I think if we are teaching people um, that they can live long and healthy lives with HIV and they can be on treatment, we can't, in that same vein, then turn around and say, but you're so dangerous that we have to criminalize you. Those two things do not match up and they don't go hand in hand. And so, um, unfortunately, I think there's just a gap that we have to bridge with that education, and with that changing hearts and minds. And we've steadily been working on it in Mississippi and a number of other states. And my hope is that as we see change in other states, that we can take inspiration from that, and that legislators will see what's happening in those states and be able to see how that unfolds, how it affects connection to treatment and care, how even people's willingness to get tested goes up. I'm really hoping that those changes out of state will help influence in-state action and pave that way to catch the laws up to what we know scientifically.
Absolutely. And I appreciate you mentioning that Mississippi in particular. Mississippi's HIV criminalization laws was written after a lot of these medical advancements made HIV more manageable. As we say, people are living and thriving. So we want to see how we could shift that narrative and that change in our policies and laws. So as we talk about the clinical setting, community care, I want to pose one last question in that area to Dr. Dobbs. How can healthcare systems measure progress in reducing stigma, and how should healthcare systems and hospitals incorporate stigma reduction into quality improvement and workforce training initiatives?
So I think this is such a great question. Um, is it problematic when you go to the doctor for them to check your cholesterol? Of course it's not. It's normalized. It's expected. We understand that it improves your health outcomes, right? Is HIV screening a recommended routine test? Yes, it is. And so it needs to be normalized. It needs to be made, normalization makes it people less fearful, right? If it's part of normal care, then it's part of our normal expectations. And so I think that's one thing for sure that we need to normalize HIV screening and prevention. As far as like an objective metric, if we wanted to measure our progress, I do think, certainly our HIV diagnosis rates, finding people earlier in the course of the illness to make sure we're having folks who are earlier in their CD4 count, like CD4 count, immune system still pretty strong. And then I think if we can get more and more HIV PrEP utilization, I think that'll be a good indicator that we're doing a better job of finding folks. Now, one of the things I do want to just jump back to the other question, I apologize for going backwards, is it's such a perverse sort of mindset. And I've had people who were afraid of getting HIV testing because if they knew they had HIV and someone else got it, then they're liable for this criminal business, right? But if they didn't know, right, then they're good, which is crazy. So there's this sort of like perverse logic that sort of exists around this nonsensical legal landscape that we have going on as well. And so the medical and the legal sort of go hand in hand.
And Dr. Dobbs, thank you. That is a wonderful segue into looking at how stigma drives HIV criminalization. And I want to pose the next question to Dominique. How does Mississippi's HIV criminalization law impact individuals' willingness to even get tested, to disclose their status, or even access care?
So, as they stated, fear keeps people away from care. That's just fear, 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 fear. We got to get fear out of here. When people are already afraid of stigma, they add in fear of legal consequences. It's like you creating another barrier, and we're trying to break barriers as we're trying to break stigma and fear. So one thing I've learned through my lived experience in working as a case manager is that people need trust, and when there is no trust, you lose them. Whether they have the resources or not, if they have stigma and they don't trust you, they're not coming. So people have to trust when they walk in a healthcare setting that they will be met with compassion and not judgment. Testing should be like a doorway to knowledge, to support, empowerment. Like, let's normalize testing. It's okay. You normalize everything else, but when it comes to HIV, we're in this little bottle. We're just bottled in. It should never be something that people fear because of what happens after their status. Like, okay, I'm positive, so now I got to tell the whole world, or if I don't, I'm gonna go to jail or I'm gonna be condemned. But you're being condemned anyway by the world because of the fear and the stigma. So, yet alone, the criminalization and the consequences legally. I mean, when the law is in effect, like the law and the science don't match, is what I'm trying to say. So the laws don't reflect what science is putting out there for us. And that's a big problem for me. It's like we're spreading outdated messages.
Mm.
Okay, but the HIV advancement is steady rising. The science is speaking for itself. So the goal should always be public health, right? But we want people to know their status and get connected. And if people don't want to know their status and get connected because of fear, legal obligations, and stigma, then we're failing public health.
Absolutely. Thank you. Thank you for that. And I want to pose this next question to all the panelists. What role can healthcare professionals play in supporting legal reforms that are informed by research and real-world experience? Dominique just laid it out. What can healthcare professionals do, and what role can they play?
Through professional organizations, of course, there's an opportunity to advocate, and that's a way to amplify voices. But also, too, physicians and clinicians of all type have relationships with political leaders, and using every opportunity to make sure that people understand the reality of it. And even with HIV, I know we've talked about the scientific advancement, but even beyond that, there's still significant lack of understanding about transmissibility in general, right? Even if folks are not treated, you're not gonna put anybody at risk, right? I mean, as far as like from routine stuff, sharing plates, touching, whatever. Anyway, but we do have a real role across the board, not only understanding how the medical advances have made a difference, but also too, that, in our normal day-to-day sort of interactions, you know, understanding what the reality is. And there's still a real lack of understanding of what the true scenario is around people who are in care and people who are not in care.
And speaking from an advocacy perspective, I see a few different roles that healthcare providers can play. The first is I think it's one thing to hear about the science from an advocate. I think it has an impact when it's coming from a healthcare professional. And they know that they can ask questions. And by they, I mean legislators or whoever your audience is can ask questions, clarifying questions, misunderstandings and misconceptions that they may have and get that clarity. And, doctors are in trusted positions in our society. And their words carry weight in a way in this setting where I think we need to lean on them to really help with that educational aspect, excuse me. I think another really unique perspective that I think healthcare providers can offer is that they're going to see how policy decisions affect patients way before legislators or policymakers do, right? When someone doesn't have insurance, right, or there are Medicaid cuts, they can't access medication. Maybe there's a delay of care because of discrimination. Um, any of those situations, providers are going to see those consequences firsthand. And so I think providers and healthcare professionals can use that experience to really inform policy discussions and advocate for systems to improve um, health and public health outcomes. I think it would carry a lot of weight for legislators to hear, like, no, Dr. Dobbs already said this. I have patients that come in and say, I'm not going to get tested because if I know, I can be criminalized. It's one thing for an advocate to say that, for Dr. Dobbs to come in and say, in my profession and in my practice, I hear that from patients. They are not getting tested because they are scared of being criminalized. It is a barrier to testing that I see regularly. I think that carries a lot of weight and can really sway legislators' minds. And they're starting to, hopefully, with these types of conversations, they perceive HIV criminalization in a different way. And instead of thinking it as a positive, they start to see how it actually can further contribute to the HIV epidemic.
Thank you, Jada. June or Dominique, did you want to address
Yeah,
that?
I would say the most people impacted by these conversations always deserve to be in the room. We can create solutions, um, but because lived experience is expertise, I think healthcare professionals have a responsibility that goes beyond the exam room. Yes, their voice matters. They hear it firsthand. Yes, providing medical care is important, but it's also understanding that the barriers that impact us, it makes a big difference. And the best thing that you can do is listen to a person that is living with HIV because all our circumstances are different. I may be middle class, you may be, you may not have the resources like I do. Like the fact is we're all living with HIV, no matter what our background or our circumstances is.
Thank you. Thank you. I'm going to pose this next question to Dr. Dobbs and Dr. Gibson. How can clinicians, and I appreciate Dominique laying out just from an advocacy standpoint as well as Jada did, how can clinicians effectively advocate for evidence-based HIV policy while maintaining public trust? Trust has come up a few times. What does that look like from your clinician standpoint?
Well, I'll start this one. I think when I heard you say evidence-based, that immediately gave me the idea that we're in the age of the anti-intellectual. I mean, people aren't the evidence, that word doesn't mean a whole lot now,
Mhm.
and we have to really be diligent about maintaining the evidence. But we have to meet people where they are. I mean, if they're not willing to read, they don't want to learn it. You have to figure out how to communicate with a person that is resistance. I do believe it requires a level of plain language with them to make sure they understand how it's happening. Where we at times in clinical worlds, academia worlds, we can speak in a different language. I think we have to be very plain language to them because again, if you don't want to pay for the care, let's prevent someone from being positive. It's much cheaper to exist under the PrEP guidelines than it is under HIV care guidelines. So speaking to them in very
Mm.
plain language, we know it's evidence, but again, that's for us. But what we have to do is make sure that we meet the anti-intellectual where that person is and ensure that they understand what's happening in very plain language and that we don't confuse them, that we make sure they get it. It boils down to food and money at this particular point. If we don't take care of this community, we're going to have more infections. We're going to have to pay more. Regardless of how your politics roll, you will not be able to prevent more money having to be spent. And throughout my entire era in HIV and STD prevention, I've never encountered a Democratic. HIV. Gonorrhea wasn't independent. Syphilis wasn't a Republican. HIV and STDs have no political affiliations. And so we have to remove them from that, but it does take a little level of plain language to ensure they understand what the evidence is.
So one of my first big mistakes when I started doing public health work is I thought evidence was sufficient, that I thought data and information was sufficient, and I was woefully wrong. I would go in, meet with legislators, and I'd have all this information. I'd be like, they are going to totally get this, and they're going to change their mind or make a decision. And it failed miserably. Why did it fail miserably? It's because trust and relationship did not precede the communications. And so we have to be engaging before we are advocating for something. We have to have relationships. And so that was key. I learned a while back that, and you get it though. I mean, who do you listen to? Do you listen to your friends or do you listen to some random person you run into on the street? You don't. I mean, you have a trust relationship. So building trust relationships and especially when it comes to people who represent us, is extremely important. Trust has to precede the sharing of information to lead to results. And that includes a community engagement too, right? I mean, people in the community trust people they trust, and it's not going to take an outsider coming in and saying something. Building trust is a critical first step to every communication.
So what responsibility, and I'm posing this to everyone, do healthcare providers have beyond individual patient care when policies contribute to health inequities?
I think we have a lot of responsibility. Who else is
Yeah.
going to do it? And I think a lot of us kind of get our heads in the sand and just do our little, churn in the clinic and the clinical stuff. But no one else has that voice and background than the people who are on the front lines. You got to come out of the trenches sometimes and go to HQ and tell the generals what's going on, or things are not going to change.
Yep.
Now,
Even if we provide the best care, if we're sending them back to a world where they're constantly discriminated against, the systemic racism is just willowed through. It doesn't matter. It's only half of my job is done because again, I can't keep them well if they enter back into the same situation and system that they were existing in. So being able to explain holistically what's happened with this patient, being able to articulate that it's not just this one thing with HIV, it's all the things that's happened with that person. So we have an overwhelming responsibility first to understand that it's not just this one thing, that it is it's a multitude of things that's impacting this person. But because we do have maybe a particular voice or particular level of power, we have to make sure that we articulate it to the people who can make the changes. Because again, it's the worst thing you can experience is when you have done all you can do for a person and they come back sick simply because the rest of the system isn't doing all they can do for a person. So it can be real discouraging.
thank you. Dominique or Jada, did you want to weigh in on that?
I just wanted to say I love the answer of like, there's a big responsibility for healthcare providers. I actually wish I would see more healthcare providers show up in the advocacy space. And I think that's hard, right? Like I understand um, the demands that are there, but I think maybe if there is some targeted um, collaboration between advocacy movements and healthcare providers, it could be really meaningful in our movement just more broadly. And I also wanted to just say, Dr. Gibson, I really appreciate you naming that if there are all these other factors that are influencing whether or not someone can stay in care, I can only do so much because I think that's another instance where I'm like, it would be great to have a healthcare provider say that to the legislature, right? Like they think that some of their decisions just don't have practical impacts that they do have on our communities. And so I think being able to show up and name how you're seeing that um, and give them specific examples really does hopefully make a difference. So I just wanted to name that I appreciated what both of you said about the responsibilities of healthcare providers.
Yeah, thank you for that. And Jada, as we kind of we've shaped up how stigma drives HIV criminalization. Let's hone in a little bit on HIV criminalization reform in Mississippi. Jada, now pose this question to you. What legal needs or policy gaps disproportionately impact people with HIV?
There are too many to name on this webinar, right? Like there are so many gaps. I feel like we've uh, covered a few of them, right? Like
Mhm.
we've talked about some of those gaps that already exist. Um, but I really want to say that a lot of those legal needs or policy gaps, like to me, the biggest one that I can think of, right, and that I'm always going to advocate for is the fact that Mississippi and other states have these HIV criminal laws. I think that that is a huge legal need in and of itself, and something that needs to be addressed in order for us to really effectively and truly end the HIV epidemic. Um, the other thing is, I really think we do have to, as Dr. Gibson was saying, like take this holistic approach of what are we looking at that's keeping people from getting help, connected to treatment and staying connected to treatment. You know, European countries have free public transportation. We don't even have that. How is someone, especially in a rural community, how are you even going to get to the doctor? That is a huge gap that exists. You know, we always tout that we're the best country, and I'm like, we don't even have the infrastructure set up to support people, especially if they're not in a major city, right? So being able to even get to the doctor to get a test, and then you're looking at, okay, if I'm have no insurance or I'm underinsured, what are the steps that I can take where I'm going to be able to get my treatment? I remember this might have been in Mississippi, it might have been in Tennessee, where someone was saying like their closest pharmacy just to pick up their medication was 45 minutes away.
Wow.
That's a
Yeah.
huge barrier to staying on your treatment regime. Even being able, if you imagine you don't have a car, there's no public transportation, and the closest pharmacy is 45 minutes away. Even how close is the nearest testing center? Where is a doctor that you can trust? If I'm a black woman in Mississippi, I want a black woman doctor. Am I close enough to be able to reach a competent black woman doctor? I don't know. I think that that's huge. So I think there are, again, too many gaps to name, too many legal needs on this call, but I think there are quite a few that have been named already that we can continue to work on and point out for folks to try and improve that access just across the board.
Thank you so much for that. This, y'all, we could keep talking and talking, but I know we're mindful it's the noon hour. I want to, before we go into Q&A, and please do we encourage attendees to, if you have any questions, to do so. I want to pose to Dominique, as a community advocates, what are some of the high points important for Mississippians to know about HIV criminalization and its threat to public health?
So public health improves when people trust the system, right? But before we talk about laws, I think we got to talk about the people. And the people matter because as someone living with HIV, I know what it feels like to receive a diagnosis. I know what it feels like to have that vulnerable moment, like processing all those emotions, thinking about your future, wondering what comes next, and deciding who you could trust. I mean, it play a big factor in your life. Now, just imagine carrying that weight with stigma on top of that, taking your medicine, going to the doctor, um, then HIV criminalization, like all that play a part. And it doesn't just affect policy, it affects the people. So if we can influence the people and just get the policy where they understand the people, then I feel like we can close some of those gaps. But like I say, the science has changed. HIV is no longer a death sentence. You equals you. Today, people living, they're thriving. I meet people every day. Um, and every day, people are looking to be judged because of their diagnosis, because they're walking into a clinic, because they got to pick up their prescription. I have people that don't even want to go get their medicine. And don't nobody knows what's in the bag. Nobody. But mentally, they feel like everybody is seeing them with something stamped and say, I live with HIV, but they don't. But we're in a Mississippi. Mississippi is where people are afraid. They're not knowledgeable. They're not coming out when we having events. They're not wanting to get tested because of fear and stigma. But say you're giving away food, it's a line. You're giving away book bags. The same way we have those type of events is the same way people should show up when we're talking about our holistically health and talking about HIV. But do they? Absolutely not. So because
Yes,
public health
yes.
doesn't improve when people are afraid, we got to reach the people. And the people are going to always remain number one because they are influential in public health.
So
So
thank you. Thank you so much for that, Dominique. We have a few questions in the chat, so I want to open that up and provide some opportunity for the panelists to respond to the attendees. One is, what can community members do to support HIV reform?
Join your state's coalition, if there is one, to work on decriminalization efforts in your state. I think that is the biggest thing, is really just showing up when you can, right? Uh, so I would say getting involved in the movement in your state if there is one. If not, and you're interested in starting your own coalition in your state, that is another way that folks can get involved. Even if it's you can't consistently show up, and maybe you could show up on a Hill Day or an advocacy day, just showing that there's strength in numbers. I think that's a big way that community members can get involved. I also sometimes think like, we can get involved in smaller ways that aren't necessarily like a broad movement as well. You should be asking your doctor, like, what's your policy on health data privacy, right?
Thank
Like,
you. Yeah.
sorry, go ahead. I was just going to say there are
No,
ways
I'm
that you
just,
can
yeah.
strengthen protections, even if it's just within your own individual doctor's office. So I think there are ways where you can show up in that capacity as well.
Oh, thank you so much. So we have one more question, and then we're going to allow the panelists 30 seconds to offer closing remarks. Oh, wait, let's see. How can, how do you actually measure whether stigma reduction is effective? What's the metric that tells you a policy changed behavior and not just language?
I think there's some objective things that we could consider downstream, sort of like engagement in care, early HIV diagnosis, and things like that. I mean, I know those seem sort of arbitrary, but they really speak to the entire system. And so there are outcomes that other states do better, that if we had a more holistic and sort of open-minded process about HIV screening and treatment and engagement, that I think it would be very obvious in the statistics. There's a lot of stuff in between, sort of process measures, but as far as outcomes, I think there are very clear things that we can see that are objective.
Wonderful, wonderful. Thank you. So we're going to allow everyone just 30 seconds to offer final closing remarks as a panelist, please. Jada?
Oh, I would just say if any of this has resonated with you, please reach out and do get involved in the movement. I know it can be overwhelming and daunting. There are folks that have been doing this work for a very long time, and they are here to show you the way and really help you amp up your advocacy and legislative efforts. The other thing is just keep moving, keep pushing. And
Thank
I'll
you.
leave it there.
Thank you. Thank you. Dr. Dobbs?
And I'll just say from a clinical perspective, first off, for patients, ask your doctor to get tested. I mean, not only for you, but also too to make it normal, right? And then that'll sort of help move the needle. For the clinicians out there, you know, make sure that your voice is heard. And if you hear something that doesn't make sense, make sure in a nice way, you know, correct misinformation to make sure people understand the reality of the scenario. There's stuff around us all the time. And even your small voice in your circle can be very impactful, sort of like ripples in a pond.
Wonderful. Thank you. Dr. Gibson?
I'll add that we know a lot about HIV in 2026. It's no longer a mystery. We know how to treat it. We know how to prevent it. So we don't have a science problem. We have a people problem. HIV is one of the only diseases. There's a couple more, but HIV is like one of the only diseases that stigma stops you from taking care of yourself. So
Mm.
it's an overwhelming thing that happens to someone when they are impacted by stigma. So one thing, just if we can just prevent this, the fact that we have the medication, we know what to do next. If we could rid ourselves of stigma, it could be a much better place for all of us.
Thank you so much. And Dominique?
That's crazy what June just said, because I would just say I want people to leave here today just understanding that HIV is just not a health conversation. It's a human conversation. And so just know you see the person before you see the diagnosis.
Thank you so much. I want to sincerely thank our panelists for sharing your expertise and your insights. And I thank each of you for your engagement and commitment to this important work. Thank you so much. And I'm going to turn it over to Lisa. Turn it back over to Lisa.
Wow, what a wonderful conversation and discussion and healthy dialogue that we hope will continue outside the context of today's webinar. To lead us in coordinating our next steps for fighting for HIV law reform in our community, I welcome Haria Tarkin, Director of Policy and Advocacy at the Mississippi Center for Justice, to lead us in our call to action and our closing. Haria?
Thank you so much, Lisa. Thank you, panelists, and thank you everybody for joining our call. This was a great conversation, and you might be wondering, well, what is MCJ doing? And why did MCJ bring me this conversation? Part of that is because we work on HIV decriminalization, and we work on HIV stigma, and our goal is to lower the number of new HIV infections in Mississippi. So how can we do that? The panelists told you, number one, they want practitioners to lock in. They ask practitioners to advocate for their patients. If we have practitioners on this call, people want you, practitioners, advocates, and community wants you to advocate outside of the exam room. Talk to people about what your patients are facing. Reduce the barriers that your patients are facing. Take patients with you to conversations about policy. Push them forward. Community, there's a call to action for you all. Ask to get tested for HIV. Let's normalize what it is. If you hear misconceptions about HIV, take it upon yourself to push back against that misconception. HIV should not be treated differently, and people with HIV should not be treated differently than someone who has cancer, for example. And then how do you join MCJ in fighting back? What are we doing? We're fighting for policy change on several different levels. And one of that is trying to decriminalize HIV in the state of Mississippi. So what does that look like for you all? Show up to the Capitol, plug in with MCJ. We'll let you know when to show up, how to show up. We'll give you talking points. When you call your legislator, if you're calling about HIV, great. But if you're calling about another issue, throw that in there. Tell them that it's something that you care about. One of the issues that we have is that HIV is only talked about in small communities. We need to make this an
Mhm.
issue for everybody.
Yes.
It is something that everybody, if we fight for human rights, if we fight for civil rights, social rights, then we need to fight for the rights of people living with HIV in every conversation that we have. So plug in with MCJ, join the HIV decriminalization network, plug in to see how else maybe decriminalization isn't your issue, but there are other issues surrounding this topic that you can plug in with. And then for anybody has HIV, we have an advisory board that you can join. So again, just stay in touch with MCJ, lock in. And our call to action, I think, is for everybody to lock in a different way. Practitioners, advocates, community, there is a way for you to be involved. You just have to find the one that feels right. And practice what you preach. So every day, if you hear something, say something. And with that, I want to thank you all for joining us, and I'll turn it back to Linda to close us out of this wonderful webinar.
Thank you so much, Harriet. As we conclude today's discussion and our call to action, I hope each of us leaves with a renewed understanding that HIV stigma and addressing HIV criminalization is a shared responsibility. We thank you all for sharing this time with us. Have an absolutely wonderful day. Thank you.